In early obstetrics, few things offer as much reassurance as a flickering embryonic heartbeat. It is the universal sign of a viable, developing pregnancy. But if the patient has a history of a prior cesarean delivery, that exact same heartbeat often creates a false sense of security for the care team. This brings us to a specific high-risk pathology, cesarean scar ectopic pregnancy, or CSEP. This image shows a normal pregnancy anchoring high up in the fundus, the thickest part of the uterine wall, far above the visible scar tissue from previous surgeries. In a CSEP, the embryo implants directly into the lower uterine segment, taking root inside the fibrotic, structurally deficient niche left behind by a prior hysterotomy. Because the sac is technically located within the uterus, clinicians routinely rule out an ectopic emergency, erroneously assuming the intrauterine location and the heartbeat guarantee a safe trajectory. In a scarred uterus, the signs that usually signal safety, an intrauterine location and a visible heartbeat, are the exact features that mask a fatal ectopic implantation. When a cesarean scar ectopic pregnancy is misdiagnosed or managed expectantly, the consequences multiply as the gestational sac expands. This is the pathological reality of a misdiagnosis, an explanted uterus where the expanding sac is rupturing directly through the anterior lower uterine segment. This occurs because CSEP and severe placenta accreta spectrum, or PAS, exist on the exact same pathological continuum. PAS is a condition where the placenta grows too deeply into the uterine wall. The ultimate result is often massive, unmanageable intraoperative hemorrhage. These engorged, chaotic surface vessels indicate advanced PAS, which frequently requires a gravid hysterectomy, the surgical removal of the pregnant uterus, to stop the bleeding. A millimeter-level spatial error missed on a routine 6-week ultrasound leads directly to catastrophic hemorrhage and the irreversible loss of the patient's fertility. To prevent these outcomes, clinicians must perform targeted transvaginal mapping between 6 and 7 weeks for any early pregnancy following a prior cesarean. Because historical nomenclature for scar pregnancies was inconsistent, a Delphi consensus panel established a standardized spatial framework to analyze the lower uterine segment. We apply a geometric model to this sagittal transvaginal ultrasound. The yellow endometrial line connects the internal cervical os to the uterine fundus. Next, the white uterine cavity line tracks the endomyometrial interface. Finally, the red serosal line marks the outer myometrial boundary. Applying this framework to a pathological pregnancy allows us to analyze the vertical positioning of the sac. This image demonstrates the low implantation sign. Notice how the exact center of the gestational sac sits completely below the midpoint of that longitudinal endometrial line. A crucial secondary feature confirming this sign is the distinctly empty upper endometrial cavity extending toward the fundus. Once a low position is confirmed, we must evaluate the anterior-posterior invasion into the muscle wall. This is the crossover sign. Here, the gestational sac aggressively crosses that white longitudinal line, pushing forward into the anterior-inferior myometrium. If at least 2/3 of the sac crosses that line toward the bladder, a scar ectopic pregnancy is highly probable. Recognizing the low implantation and crossover signs instantly flags a pregnancy that has hijacked the fragile scar tissue rather than anchoring safely in the fundus. Beyond the initial diagnosis, clinicians must track the future trajectory of the sac, a concept known as the growth pattern. This ultrasound shows an endogenic growth pattern. The gestational sac anchors in the anterior scar, but expands backward into the open uterine cavity. Endogenic growth is deceptive. It may allow a live birth, but almost guarantees severe PAS and massive hemorrhage at delivery. In contrast, this exogenic growth pattern shows the sac protruding deeply into the uterine wall, crossing the white uterine cavity line and deforming the red serosal line. This deep implantation predicts early, spontaneous uterine rupture directly toward the bladder. We quantify this rupture risk by measuring the residual myometrial thickness, or RMT. The calipers here measure a microscopic sliver of tissue, less than 2 millimeters, remaining between the gestational sac and the bladder. The direction of gestational growth dictates the nature of the catastrophe. Growing inward means PAS at delivery. Growing outward means imminent early rupture. We must also evaluate the dynamic threat of abnormal trophoblastic blood flow. As the CSEP invades, it completely obliterates the normal, structured architecture of the uterine wall. This color Doppler map, visualizing the speed and direction of blood flow, shows the visual reality of that invasion. This intense flow represents enhanced myometrial vascularity, creating high-velocity arteriovenous shunts feeding directly into the scar. A color Doppler score of 3 or 4 indicates heavy to extreme vascularity, highly specific to a scar ectopic. This invasive growth turns the scar into a high-flow vascular trap, making surgical evacuation incredibly dangerous. A primary reason clinicians miss this diagnosis is a technical error, using an improperly narrow field of view. This image illustrates the danger of overmagnification. When the ultrasound is zoomed in so the sac fills the entire frame, it hides the crucial fact that the fundus above it is completely empty. Furthermore, patients with multiple prior cesareans frequently have a retroflexed or backward-tilting uterus. This anatomical shift further obscures the low implantation site unless the clinician maps the entire organ. There are also critical differential diagnoses to consider. In this image of a cervical ectopic pregnancy, the gestational sac is embedded deep in the cervical stroma, distinctly below the level of the internal os. The most common misdiagnosis is mistaking a scar ectopic for an evolving miscarriage. A miscarriage typically presents as a flattened gestational sac that is mobile within the cervical canal, unlike an ectopic firmly anchored in scar tissue. Failing to widen the field of view or accurately distinguish a CSEP from a routine miscarriage directly sets the stage for a deadly iatrogenic intervention. Treating an unrecognized CSEP with routine section dilation and curettage, or D&C, is a catastrophic error. A blind suction catheter directed into the main uterine cavity completely misses the abnormal trophoblastic tissue embedded deep inside the anterior surgical niche. This is the result. The surgical curette punctures the thinned, deficient wall, resulting in a catastrophic uterine perforation and massive hemorrhage. The clinical mandate is absolute. Always check for prior cesareans, rigorously apply the reference lines, measure the RMT, and map the vascularity. CSEP is a critical do-not-miss diagnosis. Precise geometric first-trimester detection is the window for safe management before the surgical scar becomes a fatal trap.